A very good morning, and to begin with, I must thank Dr. Chandrima and AIOS for giving me this opportunity to speak on this forum today. Can you put my talk, please? Second last, yes.
Slides are not moving.
Yeah. Okay, so I'm supposed to speak on OCT and OCTA, which is the recent topic these days. Now, we have gone through different generations of OCT, right from time domain to spectral domain to swept source OCT, and we know that we have a diameter of 3.4 millimeter where we do scans, and as we go towards higher generations, we do have faster scanning speeds, we have better segmentation algorithms, and we have advanced acquisition techniques. So having said that, if you look at the diagnostic accuracy of time domain versus spectral domain or time domain versus swept source, they are statistically similar for detecting early or pre-perimetric glaucoma. So don't worry which OCT you have, you should know how to read it and it can be very useful. Well, there are different OCT printouts which look quite confusing when you look at that there are different machines, but basically everything tells you the same thing. We will take it segment by segment so as to understand it better. Now, all OCT perimeters, printouts give us the RNFL maps. So this is a thickness map on RNFL, which tells you actual RNFL thickness of the patient. So the hotter areas suggest the thicker areas, and thinner areas are suggested by the cooler colors. So you can see the top one, normal patient, and the bottom one is a glaucoma patient. And then you have these deviation maps, which tell you the differences from the normative database. So the yellow and the red flags are given when the RNFL thickness is abnormal as compared to the normative database. Now, we generally look for the correlation between the two because if you have thinner RNFL, you will have the flagged deviation maps. So when we have RNFL thickness analysis, this gives you the quantitative measurement, and this graph that you see, the black line, is the patient's RNFL thickness TISNET map. You can see the green, yellow, and the red areas. Now, green areas are 95% normals, and the red one are less than 1% of the normals, and that's how you get that color code according to the clock hours as well. You get to see the comparison between the right and the left eye, and you do get the intersymmetry map also, so as to understand the difference between the two eyes, so as to expect the glaucoma, which eye is more affected or which eye is affected. Okay, now the best diagnostic parameters as far as it is concerned in terms of sensitivity or area under the curve or diagnosis is considered to be a global RNFL thickness. So that is another important thing to keep in mind, that this is the factor that you need to keep in mind when you're looking at detecting glaucoma. Just to show you a case, this is a classical young male presented to us with normal pressures, open angles, everything fine, but you can see this small wedge defect there. Now, when we did visual fields for that was perfectly normal. However, OCT helped us to detect the same area of the thinning that you can see, and that's how we did a DVT for that patient and we found high pressures and treated him. So this is how OCT helps in detecting pre-perimetric glaucoma, which is the primary function we consider as. Now, what you need to also keep in mind that the pictures, it's not as simple as that every time. So this is another example where we had an elderly man who was on prostaglandin analogs already and angles being open. This is how the nerves looked like. And when you looked at the fields, it was more or less normal. When we looked at the OCT, you can see a lot of red and yellow flags. So a lot of thinning in both the areas, okay? However, since clinically it was normal and the visual fields were normal, we actually stopped the medication because patient was having the side effects due to PGA. And when we followed up this patient over next 6 years, without any medication, the patient was quite stable without any medication. So sometimes you have to be careful looking at the OCT parameters. So the red color on OCT does not always mean the disease, so you have to be careful and correlate clinically. Coming to the optic nerve head analysis, that's the another segment that you get on OCT. Now this scan determines the anterior surface of the RNFL and the RPE so that you can get rim area, you can get nerve width at the disc, You can get the cup diameter, disc diameter, and the ONH analysis results, which can tell you about the abnormalities. Ganglion cell complex is another newer thing where you have to look at the nerve fiber layer, ganglion cell layer, and IPL or inner plexiform layer thickness. Well, these maps are also presented as thickness maps, and then the middle one is the deviation map, and there's also a significance map, which clearly tells you the flagged areas as red and yellow. So this is how a normal GCC would look like, and this is how an abnormal GCC would look like. Now, let me show you an example. Now, this is a case where you can see the discs being more or less okay. I'm sorry. You can see this area looks little darker. That's why we were suspecting, and we did the OCT. And you can see there is a corresponding thinning areas in the inferior part in the right eye. When we looked at the GCC, you can see the small area in the inferior part that you can see on GCC being flagged. And the visual fields also showed us the superior area. So again, RNFL and GCC helped us detect the early glaucoma in this patient. Well, coming to OCTA, well, this is a angiography which does not require a dye. So in fact, the RBC motion works as a contrast. And what changes you see in glaucoma is actually loss of superficial vessel density in peripapillary area as well as the macular area. These are the different scanning regions that you can do. On optic nerve, you can have NFL slab, radial peripapillary slab, and choroid slab. In macula, you can have superficial and deep slab. Now, this is how a normal OCTA looks like, and you get that angioflow density measurements, which quantifies it. You can see the focal defect as here in the inferotemporal area has a lesser angioflow density, and you can see these heat map where loss of capillaries are clearly visible, and the diffuse defect where you see all around. Now, let me show you a case where there is a superior RNFL defect. You can see that, and you can clearly see that there is loss of choriocapillaries here in the ONH region and the macular region. That's how OCTA helps. Particularly in certain situations, like this is a patient who presented to us with acute ACG, and we did the PI, and after the PI and all, we did the visual fields, and you can see the right eye is quite significantly affected as expected because patient came with an acute attack. The left eye was more or less normal. In these situations, sometimes RNFL can be misleading because you can see the RNFL maps are actually showing higher thickness. That is because of the RNFL edema after acute attack, maybe. But when you do OCTA, you can clearly see the differences between the right and the left eye. This is the change in the macular region and more clearly seen on the heat map. So this is where sometimes the newer technology can help overcome the limitations of the OCT. So that's how OCTA can be useful. However, what we need to keep in mind at certain situations like this, you can see the nerves being normal, all parameters being normal, but you see a lot of abnormal areas, fields are normal. That is again that you have to keep in mind the disc size. The smaller disc can give you abnormal values, can overestimate the damage, and a vice versa, larger disc can underestimate the damage. Why? Because you have a fixed circle where you get the RNFL thickness. Now, if you have a smaller disc or a larger disc, the distance between the disc margin and the area of measurement varies. And as you go further, the OCT or RNFL thinning would be more thin. So when you have these statistical comparisons with abnormal disc sizes, you can have variable results. So always make sure that these kind of discs, you take a look at the functional assessment, and that is given more importance. Another limitation that I would like to point out is when you have an advanced glaucoma like that, the RNFL can be really low. Everywhere you will see the red flag sign. So this is called floor effect. So there is where the OCT or RNFL would have a limited role in following up these patients for progression. So you have to be careful when you're monitoring a patient with advanced glaucoma. We need to understand the limitations and artifacts that can happen. There can be operator-dependent artifacts. That means if your circle is not proper, or if there's poor fixation, if you have a high myope, if there are media opacities, and there is head tilt, and those things can also affect your results. So you need to look at the scan quality, and there can also be a clinical interpretation artifacts that need to be kept in mind. To understand, that's why it's important that diagnosis of glaucoma is based on both structure and function, along with IOP and gonioscopy. All the sophisticated tests, images, and data points should not bias our decision. We have to correlate everything clinically, And understanding the technique whenever we are using, may it be a visual fields or OCT, is very, very important before we label the patient with the disease. Thank you for your kind attention. I think we can have the next talk, Dr. Chandrima.
Yes, thank you very much, Dr. SUSHMA, for that always very wonderful talk. And yes, we'll go for the questions because Dr. SUSHMA will also leave. So we'll go for the questions. Yes, please.
Dr. SUSHMA, what about the role of OCT angio in following up these patients for progression?
The same as you would say of GCC or OCT RNFL, because you can see that sectoral, as I showed you, a focal defect. You can see as the RNFL defect is expanding, you will see the loss of choriocapillaries there also. And in certain situations, as I said, in acute angle closure or so, you may see that change earlier than you see it on GCC or RNFL.
So do we get a progression analysis on that also, like in OCT we do
No,
get
in OCT-A, you do
angio.
not have a software which gives you a progression analysis, so it will be like, you know, like how we used to hold earlier the fields side by side, so something like that.
Okay.
But you do have quantitative measurement of angioflow density, so those numbers you can look at and compare. But there's no software which will give you a GPA.
Thank you.
I have a question. Achha, you carry on, you ask her then. Yeah.
Ma'am, how about progression in the green in OCT? Progression in the green, do you start treating?
Progression in a?
Green, the progression in the green zone progression, do you start treating?
Green zone progression.
Yeah, the progression in the green as we call. When we
Okay,
are
I did not really understand. If you can clarify.
This
I
something
think it's
called the green
thinning.
disease.
I
Are you
think
talking
thinning,
about the
even
green
though
disease?
Okay, okay.
Yeah.
So that is something like if you have a, say, large disc, for example, that can be one of the cause where you can have the green disease, in the sense you will see the functional change, but you may not see a change in the OCT. So in such situations, you should be looking at the functional progression rather than the anatomical progression, because to begin with, the statistical correlations are skewed because of the either the disc size or something else. So when the baseline is not all right, you cannot follow progression on that. So in those patients, you have to depend on the functional progression.
Yeah, I have a question for you, Dr. SUSHMA. That's in OCT angiography, say the Cirrus machines from Zeiss. So in that, they give you a perfusion pressure of, say, about 44 point something, the disc perfusion, they say. So do you follow any cutoff line for that? Or how do you actually go about inferring about the OCT angiography?
Yeah, actually, as of now, we don't follow a cutoff. We are only looking at maybe a focal defect and have some normal perfusion pressures if there's a gross depression in that. But incidentally, we don't use OCTA for advanced glaucoma. So it usually helps to look at the comparison between the different segments rather than looking at the overall pressure. Well, that can be a very useful thing, I feel, particularly in normal tension glaucoma, but we are yet to learn how to particularly use it, or whether we need to look at in a particular way to modify the treatment of a patient.
Yeah, absolutely. And maybe something that we have been following is that, you know, if you do 2 OCT angiographies, say about 6 months apart, in glaucoma suspects or for NTG patients, and then if there is a difference in perfusion in the 2 of them, then maybe, you know, you could interpret something from that, or maybe advance your treatment or start your treatment, something like that. But
Yeah.
as of now, we don't have very straightforward guidelines either from the manufacturer,
Yeah.
or we do not have studies which actually are backing up to say that OCT angiography actually gives you the perfusion pressure, and this is the cutoff line for the perfusion pressure.
True that.
So, yeah.
Because they are mainly concentrating on diabetic retinopathy and the
Absolutely.
retinal vascular diseases than
Yes.
glaucoma. So that's why we have
Yes.
that a little, you know, disadvantage there.
Yes.
But I would, as you said, that we take a baseline as a patient's own OCTA and then see.
Yes.
And in those situations, I usually refer them to a cardiologist also to look at, you know, carotids and echo, so as to understand whether there's any perfusion issues which are playing
Absolutely.
major role.
Yeah, ocular blood flow as
Yes,
such.
yes.
Yeah, fine. Any other questions? Because OCT is the burning tool that, you know, of the day that we do use in the glaucoma clinic regularly. Yes.
Ganglion cell complex, if you are getting some disc tilted, disc abnormality is there, then we have to rely on ganglion cell complex. Then how optical coherence tomography will help there, ma'am? Is there any?
So when you're looking at the ganglion cell complex, so the artifacts that you get in RNFL thickness due to myopia, due to peripapillary chorioretinal atrophy are also applicable to GCC, unfortunately.
Yes,
So when you have an overlap of say myopia or any retinal dystrophy along with glaucoma, that is always a problem even in GCC. But if you have a focal change, I think I did not show that particular example where one of the patient where I could correlate a field defect with a GCC change whereas the RNFL maps were not showing any thinning.
Yes,
So in those changes where you have a focal defect and it correlates functionally, that is where you can use the GCC. Unless it correlates clinically, as I said, we cannot treat alone on the basis of a GCC change.
Okay, ma'am. Thank you.
Absolutely. On that note, however much you see changes in the OCT, it must be clinically correlated before you advance treatment or before you start treatment. Thank you. So
I have a question.
Yes, please.
What is the average RNFL thickness? Means when we will call it as a thinning or in all quadrants?
Well, that's a very good question, and it is difficult to answer because in general, the 40 or 40 to 44 is considered to be a normal average RNFL thickness, but that varies with different machines. With having so many, generations of OCT, we keep getting that as variable. But if you look at the standard taken as what is average RNFL thickness, it is considered to be between say 40 to 44. There are no particular limits, or I would say the upper limit or lower limit for each segment, but they are more or less similar. So you have to have those comparisons with age-related normals. Like how we cannot say what is the normal decibel sensitivity of, say, fovea for all patients. It can be a range if the vision is 6.6. So something like that, we can have a total RNFL thickness somewhere around that, but the other things have to be correlated along with the normative database. So that's why you get the significance maps and those color-coded maps when you have the statistically significant difference from the normals.
Now, each machine has a different range. Each machine has a different range. The size can have a different, Topcon can have a different. And unfortunately, Indian database is not available in any of the machine, normative database. So ethnicity is again an issue.
And even the specific index that is there, the test reliability, that also needs to be taken into account before you actually assign a number and take that into importance.
So that's the reason we actually don't look at the numbers. None of us have the habit of looking at the numbers. We keep looking at the color coding maps because that gives you statistical comparisons.
Yeah.
So
it gives
I may
you a
be
range.
wrong
Yeah.
in absolute number.
Yeah, absolutely.